3, 2, 1, go.
Good evening, everyone, and thank you for joining us this evening. I am Pallavi Sharma on behalf of Hetero Healthcare. Welcome you all for webinar on post-COVID complications, management options, current and newer perspective. COVID-19 virus is continuously evolving and mutating. Not only it is affecting lungs, but it is causing various post-COVID complications. We at Hetero Healthcare have always been at forefront, along with your side, to fight against this deadly virus. This evening, our esteemed and experienced doctors will share their practical experience on the subject. Before proceeding further, do let me take privilege to introduce our moderator, Dr. Sitish Roy. Dr. Sitish Roy is a super specialist in allergy, asthma, and clinical immunology. Dr. Sitish Roy is a founder of Dr. Roy Health Solution Multi-Speciality Clinic, Bandra, Mumbai. He has also been the former medical director of the esteemed Dr. Nifarkar's Asthma and Clinic Health Clinic, Dadar, Mumbai, as a senior consultant, allergist, immunologist, and asthma specialist. Prior to returning to hometown Mumbai in 2011, he was a senior consultant at the Columbia Asthma and Allergy Clinic in Vancouver, Washington, in US, where he managed 3 busy clinics, seeing both children and adults with variety of allergic, immunologic, and stress-related diseases. Dr. Roy has also been an associate professor of pediatrics and medicine at the University of MS Medical Center in Jackson, and where he also served as a director of Jackson Medical Mall Allergy Immunology Clinic from 2002 to 2010. Dr. Roy received his Bachelor of Medicine and Bachelor of Surgery degree at the St. G.S. Medical College from the University of Bombay. He then completed a residency in pediatrics at the University of Illinois Hospital at Chicago in 2000. He went on to complete a fellowship in allergy and immunology at the National Jewish Medical and Research Center of the University of Colorado School of Medicine in Denver in 2002. Dr. Roy has authored a number of articles and publications for leading medical journals, as well as a book chapter titled Stress and Allergic Diseases for the Volume 2 textbook of Psychoneuroimmunology, 4th edition. In addition to this, Dr. Roy has been a diplomat of the American Board of Allergy and Immunology, a conjoint board aggregated by the American Board of Pediatrics and the American Board of Internal Medicine. He is a fellow of the American Academy of Pediatrics, American Academy of Allergy, Asthma and Immunology, and American College of Allergy, Asthma and Immunology. Dr. Roy was listed in Best Doctors in America from 2005 to 2010, and again in 2011 to 2012, as well as in the Guide of America's Top Physicians from 2005 to 2010. So I welcome Dr. Roy and invite him to take over the session. Over to you, Dr. Roy.
Thank you very much, Pallavi, for that kind introduction, and thanks to Team Hetero for organizing this webinar today, covering a very important topic of post-COVID complications. It gives me great pleasure to be with our esteemed panelists today, who are going to help us better understand the most practical aspects of managing this very complex and evolving disease. And in order to do that, let me go ahead and introduce each of our panelists. We have with us this evening Dr. Srirang Akbari. Dr. Srirang is a consultant physician having 16 years of experience in the field post his MD. He's associated with the Uday Omni Hospital. He is an expert in the discipline of internal medicine and holds many publications to his credit in various distinguished medical journals and scientific papers like the Melting the Malignant Mass, Severe Marfan Syndrome or Case Report, and many more. So a very warm welcome to Dr. Akbari. We also have with us Dr. Sudhir Kumar. Dr. Kumar has worked as a lecturer and consultant at neurologist at the Christian Medical College, Vellore. He is one of the youngest to qualify as a neurologist and has clinical experience of over 20 years. His areas of expertise include brain stroke, neurocritical care, epilepsy, neuropathic pain, dementia, and migraines. He has over 120 published research papers in peer-reviewed national and international journals, along with multiple book chapters, monographs, paper presentations, and clinical trials. He has also published the first EEG atlas in the country called the Atlas of Electroencephalography in Adult and Child. He's on the editorial board for various journals, as you can see. And it's my pleasure to welcome Dr. Sudhir Kumar also on our panel today.
Thank you.
Last but not the least, we have Dr. Kapil Rathi with us. Dr. Rathi has been with me on several webinars starting from early 2020, and it is always a pleasure to invite him as a chest physician and infectious disease specialist, a very unique combination. He's a director at My Health Clinic in Andheri, East Mumbai, and also is attached to Criticare Hospital and Roshan Group of Hospitals, Mumbai. Welcome, Dr. Rathi. As we know, coronavirus is an old foe. It has come in a new garb. The HKU1 NL63 229E OC43, which we hardly ever heard about, but knew that they existed, causing common colds during the winter months or certain other seasons in around the world, progressed us to realize about SARS-CoV-2 in 2003, 2004, and then MERS-CoV, Middle East Respiratory Syndrome coronavirus in 2011-12. And then we were faced with, in 2019, the novel coronavirus, which we are still dealing with and learning so much about in the last year and a half. We know that this belongs to the BetaCoronavirus family. It's 25 times larger in size than SARS virus and also significantly more infectious than it, including transmission in the pre or asymptomatic stages of the disease. We know that there are 4 key variants, alpha, beta, gamma, delta, in which significant mutations have made this virus even more dangerous, as I would call it. We know that its entry occurs primarily through the angiotensin converting enzyme 2 receptors, which are highly expressed on the type 2 alveolar cells in the lung, also the upper respiratory tract, the esophagus, the upper and stratified epithelial cells, ileum, colon, the bile ducts, the heart muscles, the kidney, the bladder, you name a part of the body, and this virus can be cultured or grown from every tissue in the body. Brain tissues and even access through what is called the neuropilin-1 receptors especially makes it very concerning for some of the direct and indirect effects on our nervous system. This data is a little old, but what it shows is that we are second ranked when it comes to the number of cases, though we are also second ranked in terms of our population. We have done a decent job when it comes to the global death tolls. We are not that high. The vaccines administered are the highest in this country, but we are still only able to reach about 25% of the population, whether it's with a single dose, maybe 27%. We also know that if we take asymptomatic transmission into consideration, we may have exposure to up to 45% of the population, still quite far away from herd immunity, though our most recent serosurveillance data may suggest differently. We know that the primary symptoms of COVID, which are fever, cough, which can then progress to other symptoms, but congestion, runny nose, loss of taste or smell, fatigue, muscle ache, body ache, chills, shortness of breath, and ultimately also can present with GI manifestations of nausea, vomiting, typically between day 2 and 14 of exposure, average being 4 to 5 days. When we look at the manifestations, we realize that there are ocular, cardiovascular, neurologic, psychiatric, cutaneous, you name an organ in the body, and this virus has the potential to present through that symptom or that organ system and create a lot of problems in terms of diagnostic and therapeutic challenges. We know that COVID-19 therapies provide the maximum benefit in certain stages. The stage 1, which is the viral response, stage 2A, 2B is where the viral response is decreasing by around day 7, 8, 10, and the host inflammatory response is increasing. And then we go into the stage of hyperinflammation. We know that there are only mild constitutional symptoms in the early phases, maybe with lymphopenia and some other biomarkers later on leading to shortness of breath, oxygen dependency, changes in liver enzymes, other abnormal findings including HRCT changes which occur by day 5, 6, 7, 8, 10. And then we go into the ARDS scenario where we know with the cytokine storm all the variety of changes and problems that we face. When we look at the long-term sequelae of COVID-19, which is what we're going to focus on today, including the acute manifestations, we know that with SARS-CoV and MERS-CoV, impaired diffusion capacity for carbon monoxide, exercise capacity were abnormal in the 6 months after discharge. And even after that, even psychiatric manifestations like PTSD, depression, anxiety were still quite considerable. The pulmonary sequelae we know can be due to diffuse alveolar damage, but also we recognize that platelet fibrin thrombi and coagulopathy, especially in the small arterial vessels, can cause a lot of damage to the lungs, which we shall discuss further in today's webinar. A basic case where a 57-year-old presenting with dry cough, no comorbidities, the HRCT showing honeycombing and architectural distortion, significantly reduced DLCO with mild restriction, post-walk saturation of dropping by 5% after a distance of 220 meters. 1 month later, without any antifibrotic therapy, significant HRCT improvement. So we have to remember that there are certain aspects of the disease that can resolve naturally, but then we also realize that there can be a lot that does not resolve naturally in up to 20% or more patients. And in such cases, recognizing the extrapulmonary manifestations, where we are going to focus on the respiratory and the neurologic, where we can see everything from loss of taste and smell all the way to stroke and encephalopathy and Guillain-Barré syndrome are issues. And thromboembolism, which from deep vein thrombosis, pulmonary embolism, catheter-related thrombosis, and clearly a lot of other complications, including cardiac complications, myocardial ischemia, are all a consequence of this disease. So we will focus on certain areas today. We also have to remember the long COVID manifestations, which we really won't go into a great detail today, but dyspnea, cough, persistent oxygen requirement, chest pain, post-COVID ILD, which we will discuss, and amongst neurologic brain fog, which remains one of the most common long COVID manifestations, but also loss of taste, smell, encephalopathy, the consequences of stroke. We're going to discuss about how we can prevent our patients from getting into these where possible. I shall not belabor this topic, but recognize that there are even complications like Parkinson's, dementia that can occur in some of our patients, and we'll speak more about it. And at the very beginning, before we get into our discussion, I would like to tell all our doctor friends who are joining in that take care of your own immunity, because you can take care of patients only when you are healthy yourself. There's nothing better than fresh air, sunlight, a healthy diet, good exercise, good sleep. Some of our ancient healing techniques like yoga, pranayam, meditation go a very long way in keeping ourselves well. We shall discuss a case now, and with that case, we shall use that as a launch pad. This is a post-COVID-19 pulmonary case, a 57-year-old male presenting, having no comorbidities, presenting with breathlessness, dry cough, and gastritis. Examination showing that even with 4 liters of oxygen saturations are barely 94%, heart rate is 80 per minute, BP is 130/90, the breath sounds indicate bilateral crackles. The patient had a CT angiogram which showed mild pulmonary arterial dilatation, mild pericardial effusion, no thromboembolism, fibrosis with traction bronchiectasis, suggesting that changes were already occurring in the lung. There was severe pulmonary hypertension, thin rim of pericardial effusion, severe restriction and severe reduction in diffusion capacity, total lung capacity reduced, post-walk desaturation of 9%, distance covered about 260 meters. The CT scan initially, which had a score of 16/25, developed pneumothorax, pneumomediastinum, later on pulmonary fibrosis with traction bronchiectasis, and several other changes, as we can see with the pulmonary hypertension. After starting on antifibrotic therapy, there was definite changes and improvement that was seen in traction bronchiectasis and honeycombing. So this is a classic case of post-COVID fibrosis with pulmonary hypertension. This is some of the management features. And so with that kind of a case, I would like to come to our discussion for today. And I would like to ask Dr. Rathi, Dr. Rathi, in terms of the manifestations of COVID-19 during the first wave versus the manifestations during the second wave, do you feel that there have been changes in how this virus has been affecting human beings, how it has been affecting our lungs? Are there some key features that our audiences should know about so that they are quick to pick up these differences? And do you really think that the Delta variant has done something different with regards to the manifestation of COVID-19?
Yeah. So thank you, Dr. Sitish, for that question. At the outset, let me thank Hetero for inviting all of us for this, a very important discussion. Probably a lot to learn from each other. So as you rightly pointed out, there are subtle differences between, first wave and second wave. Probably because we were aware of, the symptomology on the first wave. So probably we were more prepared for second wave. But then again, virus has fooled us for at least a couple of symptoms more, which were, predominant in second wave. So right from pulmonary symptoms, right, like cough, breathlessness, or shortness of breath, or little that, the fever was very prominent in second wave. So probably a lot of people were having, continuous fever, which was not very high grade in first wave, but was quite high grade in second wave and lasted for a little longer period. Initially in first wave, it was for a couple of days or 2-3 days, not going beyond 100, 101. But this time we have seen typically in our part of country that there were a lot of people who were presented with long fever. Long fever means more than 4-5 days having continuous fever instead of taking paracetamol and everything. So that was very unique feature this time, probably because of variant. Number two, there were a lot of extrapulmonary symptoms in the form of gastric symptoms, which we patients presented, like abdominal pain, diarrhea, nausea, vomiting. Also, there were a lot of patients presenting with nothing except severe headache, a lot of fatigue, a lot of pain and everything. So aches and pain. So these were a lot of symptoms which traditionally we used to differentiate into some other infectious causes. But looking into the pandemic, we were forced to do all this tests, and to our surprise, a lot of patients turned out to be COVID positive. So that was a quite distinct, features from say phase 1 to phase 2, or so in the second wave. So we have seen not only pulmonary but a lot of extrapulmonary symptoms. So we have to really keep our antenna up in the second wave, and probably we should keep up in coming days, so that because this virus, as you have told, it can go to any part of the body. ACE2 receptors are present everywhere, right from your nose till your toes. So it can hit anything, and patient can present with isolated cutaneous symptoms or probably neurological symptoms. And we have seen patients are presenting very late, because we have seen in the second wave, the young population was more affected. So probably their tolerability was a little more. So they are presented late to us. And probably they presented in a bad fashion or with more complications as compared to first wave. So that was my overall view between first wave and second wave.
Great. Thank you very much, Dr. Rathi. Dr. Srirang, I would like to come to you now. And the next question is directed to you. In your experience, with the way the COVID-19 virus has been behaving, are there certain red flags or certain concerning features in a patient, whether it is clinical, whether it is biomarker related, whether it is investigation related, that our audiences need to watch out for so that they can recognize which are those patients who are not in the mild or the mild moderate category, but can actually progress to having more severe or critical disease, or get worse even if they are hospitalized with the intention of just monitoring and observation, or a little bit of oxygen requirement. So your thoughts about the red flags and concerns and biomarkers that you feel would be very relevant for monitoring our COVID patients.
Yeah, the red flag signs, as you said, are very important, because that makes the difference on timely referral to a hospital, and then you can save a lot of lives. Initially, when we began with the first wave, our impression was it was largely mild disease in 85% of the patient. But as Dr. Kapil said, that perception got changed in the second wave. If we want to discuss about the red flag signs, we can classify them, as you said, into clinical, then lab-related, then maybe radiological. So history-wise, any comorbid conditions actually puts a person at increased risk. So we need to take a detailed history because same symptoms in a person who's got diabetes, hypertension, uncontrolled, or chronic liver kidney disease or chronic lung disease, immune suppressive state because of either medication or an immune autoimmune disease, a malignancy, etc., puts him at a higher risk. Again, elderly people more than 65, they are at higher risk of complications. So you need to be very careful and then observe them very closely. Some hospitals even have a protocol that even mild disease with these risk comorbid categories, they actually hospitalize them in wards probably so that sudden deterioration can be noted. Coming to clinical examination, symptoms of the patient are very important. Sometimes they don't fit into our scheme of things and we tend to neglect them. But somebody is feeling short of breath. Saturation is showing good, but he's feeling breathless. Please respect the symptom. Any history of chest tightness, chest pressure is again very important indicator that is about to worsen. As we all know that fever and cough are the manifestations initially, but persistence of fever beyond 5 to 6 days, cough which is actually persistent or increasing at 6 or day 7, now that really makes you feel that this is something wrong. Because I think a lot of people have, we've lost a lot of people because we're just sticking to that hypoxia point to really start them on antivirals or steroids. But these are very important categories, and AIMS in the recent May protocol actually included that persistence of fever, cough, even in mild category, you can actually start them on low dose steroids. Other pattern could be that somebody has a fever initially, fever came down, but recurrence of fever at the end of first week, again, is an important red flag sign that something is not going right. Again, the biomarkers, all of us are aware that biomarkers like CRP, then you have D-dimer, interleukin-6, ferritin, if they are elevated, or serial measurements rather would be more indicative of worsening disease, then they also need to be taken. But these biomarkers, again, we need to understand that they need to be taken into the entire clinical context. There's also a lot of issues with IL-6 where people do it on day 1, day 2, and then they try and see, but the patient is otherwise all right. So we need to take that into total clinical context. Again, would be a clinical examination, persistent tachycardia. So if somebody is having a very high heart rate, it's a very ominous sign in general medicine and even in COVID-19. Persistent tachycardia may be actually harbinger of actually bad things to come future. Second thing would be somebody who's having bluish discoloration of the lips or face. Child, if it is there, is not feeding well. Somebody, elderly person actually is getting actually confused. Sensorium is altered. Now, these are very, very important signs. And if any one of these are present, you, despite the oxygen saturation being normal, please rush them. Obviously, oxygen saturation less than 94, you need to really be on your toes. Or somebody is having a exercise-induced or walk-induced desaturation, that again is an important sign that, okay, he's going to worsen. So be ready, or better to admit him if the resources are not available in that particular area. Other things would be a high NLR, that is neutrophil lymphocyte ratio. Any neutrophil lymphocyte ratio more than 3.5, again is a pointer that things are about to worsen, and therefore be very alert when you observe a CBP. Just don't see the count, the differential count, NLR ratio is again very important. With regards to radiology, we've seen that ground glassing widespread. We calculate the CT severity score. That is an indicator that it's likely to worsen. But certain radiologic patterns again may tell you. Suppose somebody is having a dense consolidation. That tells you that he's going to worsen. The ground glass appearances, most of the times when you start steroids, they respond well. But these parameters like dense consolidation, they are actually ominous sign that they may actually be harbinger of further complicated course. These signs, if you actually broadly associate and then carefully watch for, you can actually save a lot of lives and then timely refer them to the hospital.
Thank you very much, Dr. Srirang. I think that was a very thorough and carefully thought out response that you gave us, taking us right through the clinical manifestations to the biomarkers and the radiological investigations. And like you rightly said, IL-6, while initially was used a lot, I think people realize that the way it is drawn, the way the sample is processed, the timing of the sample processing, and the availability of the test were all issues. And hence, many people have moved somewhat away from following those numbers unless they can be done in the right way, and following more in terms of the clinical picture, other biomarkers of inflammation and the D-dimers more than anything else. So I think and I think in general, the IL-6 or the tocilizumab kind of drugs, people have realized the very limited application of those therapies in these days. So I think those are things we have learned through the first wave and the second wave and can do better. So Dr. Sudhir, I would like to come to you with the next question. In terms of the neurological manifestations. We know that there are a lot of things that COVID-19 can do, some directly, some indirectly. Can you take our audiences through some of the manifestations that you in your practices and in your hospitals have been seeing, and give us some insights into what people should be looking out for when the need for a neurologist comes in, when the certain investigations may be required. So what are those manifestations in terms of both during the acute phase and in the post-acute phase?
Yeah, thank you, Dr. Sitesh, for doing the discussion very well so far, and also the Hetero team for organizing this very useful, informative webinar. And I welcome all the viewers and all the doctor colleagues who are who are here for this webinar. Now, coming specifically to this topic of neurological manifestations, unfortunately, they are not uncommon. So we frequently see many of the neurological symptoms also. And if we look at, if we classify into common ones and uncommon ones. So common things that we see are already listed: anosmia and dysgeusia. So loss of smell and taste, which have been mentioned as one of the presenting features also. And they look very trivial, but it's quite annoying for the people who suffer from it. Only those who lose it, they realize the importance of having good smell and taste. They are closely linked. So they have to enjoy the food also, and and if someone doesn't enjoy the food, then the entire day is gone. And they have a lot of anxiety. What will happen? How long will it last? But luckily, they don't last forever, and they get better within a few weeks to few months at least. And the reason for loss of smell is that one of the port of entry for the virus is through nose, and there are good MRI studies which have shown edema of the olfactory bulb and the olfactory nerves. And then that could be one of the ways the virus can enter the brain also, especially if they break in the cribriform plate of ethmoid. But luckily, that's not the very common mode of entry of the virus to the brain. And then other common symptoms are myalgias. Like any viral fever, we are all used to body aches and pains. But somehow the myalgia in COVID patients, it is much more than other viruses. So they suffer a lot. And I have seen patients who have been physically fit and doing, let's say, they're all my colleagues also who have been good bodybuilders and doing gym workout for 2 hours. But post COVID, for a month at least, they could not walk for even a kilometer, and they find it very difficult to climb stairs. They say the moment I start walking, I get severe body pains and myalgias. So they are quite disabling, and people feel handicapped. But the silver lining is that after a month or so, most of them get better. And if we don't need to do any test for this, but if somebody has severe myalgias, serum CPK can guide us whether there is more muscle breakdown or not. And one more common symptom that we see is headaches. So headaches, I see there are of two types. One is that people who had prior migraines, but they were infrequent, like they used to get once in a month headaches or twice in a month. Now they start getting almost every day or every alternate day. So headache frequency increases, and also the severity increases. And the second category is that those who never had headaches before COVID, they get new onset headaches. Now, when headaches come, they are typically fulfilling all the symptoms of migraine or tension type headache. We can just start treating. But again, if there are some red flags like very severe headaches or any other focal deficits or fundus showing papilledema or any other findings, you must do a brain scan to exclude conditions like cerebral venous sinus thrombosis and other things. So there are common symptoms. Less common manifestations in neurology we see are strokes. Strokes can be both arterial and venous. In arterial ischemic strokes, then hemorrhagic strokes, and even cerebral venous sinus thrombosis. So all these three types of strokes we see. Luckily, they are not common because if it is common, it will be quite disabling, and we see them mostly in patients who have severe COVID-19. But we should not feel that only severe COVID patients will get stroke. So we have seen strokes as the presenting feature. The patient did not have any COVID-19 symptoms. They come with a routine stroke, and then we start treating them. On day 3, day 4, patients develop respiratory symptoms, and then we check the COVID-19, RT-PCR, and comes positive. So I think the initial manifestation may not have any typical COVID-19 symptoms, just the stroke, and then after a few days in the hospital, they show typical COVID-19 symptoms. Then CNS infections. So both meningitis and encephalitis have been reported and we have seen, but they're also uncommon. Seizures. So seizures, again, there are two types. Those who are already known epilepsy patients, they can have a recurrence of seizures because of high fever or hypoxia or some of the drug interactions. And second is those who never had seizures, they can also develop new onset seizure, but these are again uncommon manifestations. And one more is Bell's palsy. So Bell's palsy, as we know, it's a post-viral, facial paralysis, and mostly herpes simplex has been implicated. But there have been several case reports, and I also have seen many cases where, in the initial presentation itself, patients can have Bell's facial paralysis, and sometimes post-recovery they can come after 2 weeks, also with facial paralysis. So these are the common and uncommon symptoms. And then second part will be post-COVID. So somebody who has recovered from COVID has been discharged and sitting at home. Can they have neurological symptoms? So answer is yes. And some of the previous symptoms like anosmia and lack of loss of smell and taste can persist even after discharge for several weeks. As I mentioned, headaches and myalgias can persist. And I have seen few patients where even anti-migraine drugs don't work. So they have sometimes disabling headaches. So we should not just pass it off saying he's just stressed or anxious. They require a lot of caring and good medicines for them to get better. And then one more thing which Dr. Sitesh also highlighted about this brain fog. And so I have seen patients who say that I don't feel totally normal, my mind is dull, I can't remember things. So these symptoms are common in the first 1 or 2 or 3 months, and then then gradually they do get better. And then sometimes we see this post-COVID Guillain-Barré syndrome. So that's again uncommon, but I have seen at least 4 or 5 cases where patients have gone back. So typically, as you know, it's a post-viral syndrome, GBS, and so patients get better. Then the antibodies cause involvement of the roots and the nerves, and then they come with the presentation is similar, like non-COVID or post-COVID. The manifestations are same, treatment also is same, and they respond to IVIG and plasma exchange. So I think they are the main symptoms we look for, and I think most of the symptoms and diseases are well known. If patient has those symptoms, then we do the appropriate tests, and and treatment also are similar to COVID and non-COVID. There's not much difference.
Correct. Great. Thank you very much for leading us through all of that. And I think it just goes to show how much this virus can do and how many manifestations it can have at various stages. Important of having patients who present with a stroke and later on get diagnosed with COVID-19. And I think this has been seen in every faculty and specialty. There have been people coming with heart diseases, acute myocardial infarction, so many other issues where later on it was found that COVID was the reason to precipitate what might have been already brewing in that person's body for whatever reasons, their comorbidities or etc. Dr. Rathi, I'll come back to you with a little change of gear from the nervous system again back to the respiratory system. And the question I have for you is, we have spoken about the HRCT chest, and we recognize that this is a very important investigation. We all recognize that there is a right time to do it and a wrong time to do it. So can you lead our audiences through some of your insights and thoughts about what is the right time to do a HRCT chest, and when would you want to repeat it if it needs to be repeated, and how can that help us in just the overall management of our patients?
Yeah, so I think that is very important question, when to do and how to follow up this patient. So as we all know, we are probably overdoing HRCTs, in last 6 months or so. Probably we were not well versed in the first wave, but then first wave taught us that CT is something which picks up very early disease, or probably give us a better inside view of what is happening inside the lung, so that you can plan your treatment very well. So that's the reason we have been doing it quite oftenly, and people are also doing it because there is so much of media and everything, and people know CT is much better than X, and we all know that. So what we were seeing in the second wave, a lot of people were coming with and already a CT scan done from outside, and then they come to you saying that, boss, I got RT-PCR positive, and the day their RT-PCR positive is there, they do a CT scan and they come to us. So I think that was absolutely not required, and this is absolutely not a good practice, because we all know CT takes at least, the lung changes at least take 4 to 5 days of a so-called, the symptomatology or the pathogenesis which happens from upper to lower airway. It takes almost 4 to 5 days to go that virus to come down and create that alveolitis or the GGOs or whatever the CT findings are. So the right time to do a CT will be probably day 5, day 6 of the symptoms, rather than actually the day 5, day 6 of RT-PCR. It should be on the basis of symptoms, and probably we will do it right away on day 1 if patient present to you with all the the red flags what you were talking about. So for a walking talking patient, for a normal patient who has just come as an RT-PCR positive or a probable suspect or probable high risk patient, probably I'll do it on day 4, day 5 to actually get the picture whether the disease has progressed or what is the state. And probably I'll repeat a CT scan if there is a clinical deterioration, or if you feel that the patient is going bad, or the saturations are going down, oxygen requirement is going up, or there is something which is coming up, say a new fever, or probably a worsening of existing the hemodynamics. So that will be my threshold to do a repeat scan. Otherwise, for routine purpose, I'll do it on day 5, day 6. That too, and believe me, or I will be on the record that we don't do CT scan for each and every patient who comes to you on an OPD basis. So probably your 70-75% of the patient who are treated on OP basis hardly will require a CT scan. Maybe some special category will require. Otherwise, we generally do it on day 4, day 5, day 6 of a symptomatology, and probably repeat if there are clinical deterioration, or probably on the day of discharge if you really want to see whether there is a fibrosis which is setting up or not. So that is my overall view on when to do a scan.
Great. Thank you very much. I think it's a very important message for people to hear that CT scans are being overdone. We've all felt that way. It definitely has a role when you have a patient who is having multiple negative RT-PCRs or a negative RT-PCR and a negative rapid antigen test, but you have a high clinical suspicion of the disease. And sometimes the HRCT can seal the diagnosis by the classical radiological appearances that we may see. But at the same time, doing it early and missing a case which then worsens or comes back because people think, okay, my RT-PCR is negative, my HRCT is negative, I don't have COVID. And sometimes those have also led to some disasters, as we would say, due to late presentation then. Dr. Srirang, I would like to come to you with the next question. And my question to you is, in your practice and experience, what are some of the complications that patients are facing these days in the, so we are now primarily talking about the hospitalized patients and following them, and what kind of worsening, what can lead to ICU admissions, what kind of complications are being seen, because I think from there we can then discuss what can we really do about these things. So your thoughts, your observations, and your read on the literature, please.
Yeah, especially in the second wave, we've seen a lot of patients, the percentage of them presenting with moderate disease or worsening was very high. So once they present, the predominant complaint would be breathlessness, and then you find varying degrees of pneumonia slowly evolving into ARDS. They may also present with other organ system manifestations, and then they confuse us. As Dr. Sudhir said, they may come with a stroke or meningoencephalitis. They may have varying degrees. Gastroenteritis was a common presentation. Some of them presented with vertigos, etc. Acute coronary syndrome is not an uncommon manifestation. Somebody landing up with acute coronary syndrome or even heart failure because of myocardial involvement. So all these are common. Some of the people are otherwise on these diseases, especially ARDS, etc., can then develop a lot of other complications, as you presented in a case like a pneumothorax. You can have hemoptysis. Pulmonary embolism is well known. So these could be the common complications which they encounter. And eventually, when they go into critical disease, you have a septic shock, which is refractory to many of the things. Other common manifestations sometimes would be they presenting with renal failure due to the affinity of the receptors there. Presenting manifestation would be a renal failure, and then you evaluate, you have a, so various the critical vital organ systems with involvement can have varied presentations. The lung involvement, which is the most common form, will actually present with severe pneumonia going on to ARDS, and then you'll have to take care of the ARDS. Treatment strategies obviously will depend on the degree of hypoxia and then the patient profile.
Great. And I think at the root of all this, I think all of us would agree is that the thromboembolic, the microcoagulopathic changes that this virus is capable of doing and increasing the risk of what we would call microthrombi, clots, and blood-related problems is what is at the root of many of these issues that you're describing. And I think that it becomes very, very important for us to recognize that. And I think that has been one of the advantages that we got through our lessons that we learned in the first wave around the world. with places like Italy, China, US publishing some of the early data when they did the autopsies finally on patients and detected these clots and realized that, just pumping them with more and more positive pressure ventilation or doing those kind of things is not the answer. And we really need to work on the clotting that this virus is promoting or inciting. Makes all the difference. And as you rightly said, the manifestations are myriad of that, along with the damage that the virus itself does in the lungs or other organs, as we discussed. So the next question I have is for Dr. Sudhir, coming back to you. Are there, we spoke about the strokes in COVID-19. Are there any differences in the different types of strokes and in terms of the manifestations? And is there anything particular about the presentation or treatment that is different when it comes to COVID-19? And your thoughts on that? Because as you said, there are arterial, there are venous, there are different timings of when they happen. So a little bit about the manifestations and the treatment in relation to specific COVID-19, your thoughts on that?
Yes, I think it's a very important question to note, because stroke is one of the top 3 or 4 leading causes of death and disability, other than heart attacks, cancer, and road accidents. And strokes happen. And if you look at the comorbidities that lead to severe COVID-19, like diabetes, hypertension, dyslipidemia, obesity, so these factors are common they're common risk factors for stroke also. So that is why those who have severe COVID-19, they're also at a higher risk of strokes. And there have been various studies now over the last 1.5 years where people have published data on strokes in COVID-19. So initial report suggested that almost 5% of COVID-19 patients can get stroke. But fortunately for us, the numbers are not so high. In the latest papers, that has come down to about 1.2%. So out of every 100 COVID-19 patients, 1 to 2 will have strokes. The most common strokes still remain arterial strokes. So they are ischemic strokes, ischemic, or in that both thrombotic and embolic. And patients who have already atrial fibrillation, again, they have a higher risk of stroke, arterial strokes. The second type of stroke, which is less common, is hemorrhagic stroke, where there is a primary brain hemorrhage. And the third one is cerebral venous sinus thrombosis, where there is a clot in the venous sinuses. And the manifestations are similar in COVID-19 and those without COVID-19. So, and I'm sure our doctors know, so I will not go into much details, but any focal neurological deficit which happens all of a sudden, one should suspect stroke. In that, the common symptoms we see are aphasia with right hemiparesis, left hemiparesis, or somebody who becomes, has a drop in sensorium, so GCS drops suddenly, or somebody starts complaining of severe headaches with blurred vision and seizures. So that's a finding of venous sinus thrombosis. And initially, of course, we have to go for a CT scan to differentiate ischemic stroke and hemorrhagic strokes. And here I want to highlight that because in COVID-19, there are so many precautions people take, especially in the first wave, because we need to isolate the patient, then staffing is different, then again sanitize the patient. So a lot of things were there. So what we found is that this was leading to undue delay. And as you all know that the thrombolytic treatment is time bound, it can be given only in the first 4.5 hours. So many stroke patients who had COVID-19 already known or suspected, because as soon as patient comes in, we have to do RT-PCR. That's a protocol in all hospitals, even now. And and reports do take time and things like that. So there's some kind of delay. Now, of course, the timelines have reduced and we get reports faster. And some hospitals also had to do HRCT, if there are no symptoms, because that time this RT-PCR and other tests were taking much longer time. So as a screening, it was used. So what I meant is because of this, need to isolate the patients, the staffing, and it was leading to undue delay, and that the delay has come down. And that's why many patients who could have been thrombolized were not thrombolized. And other point I want to highlight is the mortality, because many times patients who have, just stroke, they recover much faster. But stroke in COVID-19, the risk of, severity coming faster, or, the length of hospital stay, then the chance of risk of death, all were slightly higher, definitely. So many times we have to just, suspect that patient could be having COVID-19 and then start, because we have seen patients who were almost recovering and then day 4, day 5, COVID-19 symptoms started. and then that made them much sicker. So if we preempt, pick up COVID-19 symptoms earlier and institute the COVID-19 treatments also along with the stroke treatments, then the outcomes are better. And then there's a role of doing few markers, like it was already discussed, inflammatory biomarkers like D-dimer and CRP, ESR. So when these markers are elevated, then the risk of stroke is much higher in such patients. And so we can preempt that. Yes, if D-dimers are high, we can watch for early signs of neurological symptoms, because we have to diagnose and treat within the first few hours, and things like that.
Great. Thank you very much. I think that's a very good, insightful answer that helps our audiences look at these in perspective and be prepared to take the right decision and the right timely decision, which is, as you said, so critical when it comes to strokes in terms of intervention and treatment. Dr. Kapil, I would again change gears and come back to the respiratory system one more time and want to ask you that in terms of patients who post-COVID are at risk of developing pulmonary fibrosis, what are some of the risk factors, or what are some of the features, whether it is their clinical features, whether it's their radiological features, whether it's their comorbidity features, that would help our audiences recognize or identify which are those people who are at higher risk for post-COVID fibrosis? And if so, are there any interventions that can help these people in terms of treatment? So your thoughts on that?
So there are certain features or certain certain phenotypes where you can get fibrosis, where you can anticipate fibrosis. For example, so say if there's a patient who's already underlying comorbid like diabetic, hypertensive, or an COPD, asthma, or any kind of immunocompromised status. So these are patients who are at high risk of developing fibrosis. Number two, patients who are obese or who are having a long ICU stay or long hospital stay for that matter in COVID. So typically more days stays in the hospital, requiring a lot of oxygen in the course of the treatment, or having a lot of positive pressure ventilation. So these are typically your patients who were having on HRCT, who were having dense consolidation, typically on the basis they were having dense consolidation. So probably that area will have a lot of traction bronchiectasis and things like honeycombing. So these are the typical features where you can anticipate that this patient might get fibrosis. Obviously, other than that, the patient is very high, having very high markers still at the end of 10 or 12 days or 15 days. That is another thing which runs in your mind along with the clinical symptoms. So these are certain things, certain features from radiologically, certain features from biochemically, and probably most of you are with the underlying comorbidity and the clinical, the course of the disease which has happened over a period of time. So that will actually decide whether this patient will get fibrosis or not. But believe me, there are only 15 to 20% of the patient who are admitted or getting discharged will have this problem, probably at the time of discharge or probably in coming 2-3 weeks. So not every patient, even you will agree to me that a lot of patients we have seen who are very sick to start with, absolutely hell and hearty while on discharge without having any clinical or radiological symptoms on a CT scan. So we have seen two contrasts. So where normal patient going absolutely bad and getting fibrosis, and really sick patient whom you actually were harping that this patient might get long-term post-COVID sequelae turn out to be absolutely fine. So this is very unpredictable, which can happen. It all depends on a lot of cytokine interplay, a lot of your immunology, a lot of your own immunity, a lot of other environmental risk factors, as well as your own comorbidity, which plays an important role in developing fibrosis.
And do you feel any intervention can help, Dr. Rathi? Do you feel that any therapeutics can help in this, in terms of, we have known initially in the first wave, we would talk about wait a month or two before you started antifibrotic therapies, things like that. Are there, in these high-risk patients, let's say, if you're repeating a CT scan before the patient is being discharged because they've had, as you said, a stormy course or a rocky course, or they've had certain features that make you more concerned, in such cases, is intervention, you think, early intervention of value and help?
Yeah. So I think, yes. Again, coming back to the same point. So these are the patients where I'll do a repeat scan on the day of discharge, and I'll see what is the lung status. Probably we all know, the lung changes, or that GGOs and everything takes at least 4 to 6 weeks to get totally disappear. But then you can get a subtle features of traction bronchiectasis, or a little bit of dense stranding and everything, which indicates that this patient is getting fibrosis. Plus a requirement of an oxygen, probably home oxygen, a couple of liter, or a 6-minute walk test which fails out, or patient is too sick to to walk or to climb. Probably this will indicate that this patient is on the verge of developing fibrosis. So probably this patient will start antifibrotics. I think we are more aggressive in second wave rather than in first wave in starting antifibrotic. We anticipate more early. There are some clinical criteria where we can start. So this patient might require good physiotherapy, good respiratory exercises or respiratory hygiene, and obviously an antifibrotic as a therapeutic intervention where we can actually prevent from that disease getting really bad and patient getting really sick. So yes, antifibrotic in the form of either pirfenidone or nintedanib is our drug of choice as of now, what we start in our patient, but it all depends on case-to-case basis. But at least we have got something to offer to this patient so that patient actually lives a quality life.
Great. Thank you very much. Dr. Srirang, I would like to come to you with the next question. And my question to you is, we've spoken about the coagulopathic changes that are very prominent in COVID-19, and just your observations on some of these coagulopathic complications and which anticoagulant pathways or therapies do we really need to focus on in order to prevent some of these? You have very nicely outlined all the complications that these patients can go into in your previous response. So some thoughts on the coagulopathic complications and the anticoagulant approach or intervention in post-COVID or in acute prolonged COVID, as we may call it, in patients who are with us for more than just a few days and get well and go home. So your thoughts on that?
As the COVID pandemic evolved, we started with the infection, which is a predominantly respiratory infection. Then we came to know various other effects. And as you rightly said, microthrombi are actually one of the classic manifestations which are actually responsible for varied clinical presentations. So as anti-inflammatory modality or drugs are as important, so is anticoagulants, and they probably form the real backbone to prevent a lot of possible preventable side effects. Now, in terms of thrombotic tendencies, we have seen cardiac issues with acute coronary syndromes, we have seen strokes, pulmonary embolism, etc. So we need to anticoagulate. Now, initial guidelines were not very clear on how to go about that. Our revised protocol by the Ministry of Health and Family Welfare now actually tells broadly about using these anticoagulant therapies in two classes of patients. One is moderate disease and one is severe disease. In moderate disease, what is recommended is low molecular weight heparins in a prophylactic dose, and in a severe disease, we go into a therapeutic dose. That is what is recommended. But it is not very simple. We need to really assess the other background conditions. What is the bleeding risk of the patient? What is the thrombotic risk of the patient? And then take into account what anticoagulation is actually needed. In hospitalized patients, we would definitely prefer a heparin. Coming to the unfractionated versus the low molecular weight heparin, we definitely prefer low molecular weight heparin because you do not require monitoring, less sampling, less contact with the patient. So low molecular weight heparins are much preferred. But if you can have a formal assessment of both the VTE risk and the chance of bleeding, then we can actually take into account what anticoagulation is best for him. Certain markers like D-dimers will definitely help, but by the time D-dimer is actually elevated, you possibly already have had some amount of microthrombi, and then you don't wait for it to start, but a serial measurements may actually tell you that maybe things are settling down. If you can share the slide, I can go about discussing the algorithm which has been very elegantly given by the Tamil Nadu government and the health mission there, and which classifies basically how to go about planning your anticoagulant strategies. Now these I would like to present first because these are the Indian local guidelines which are there. There are other guidelines as well from different societies, including the American Society of Hematology, then British BCHS, that is British Standards of Hematology, etc. But we'll first go through them. Now, if you can see, we classify the disease into mild, moderate, severe, or critical, and then we assess for every patient the bleeding risk. If the bleeding risk is high, we do not anticoagulate, and if the bleeding risk is low, then we assess what is the risk of thromboembolism. Is it low or high? So mild disease, low bleeding risk, but low thrombotic risk, no anticoagulation. But if you have a high thrombotic risk, actually a prophylactic dose of low molecular weight heparin is indicated. Again, moderate disease, if the bleeding risk is high, then you would again consider very carefully whether to anticoagulate, because you don't want a patient to bleed in time to protect it. But if he has got low bleeding risk, then the risk, if it is low of the thrombotic tendency, you give a prophylactic dose. But even in moderate disease, you give an intermediate dose if the thrombotic risk is high. Severe or critical disease, if the bleeding risk is high, you still give some dose, at least a prophylactic dose. And if the bleeding risk is low, then calculate the score, and based on that scoring system, ICTH score more than 5 or high risk features, if they are present, you give a therapeutic dose. If that is not there, calculate the VTE risk, and then based on low or high, you give a prophylactic or intermediate dose. Now, what are these doses and what are these scores? For example, commonly we use enoxaparin as a low molecular weight heparin, and 40 milligrams subcutaneous for an adult patient would constitute a prophylactic dose. Intermediate dose would be about 1.5 times, around 60 milligram once daily, and a therapeutic dose 40 milligram twice daily. 60 milligram twice daily, I'm sorry. Next slide, please. Coming to the scoring systems, this is very elegantly presented here. Now, 3 scores are there. How to calculate the scoring system is you have the Padua score, you have the Hasblad score, and the ISTCH score. Now, based on these scoring systems, you actually calculate what is the risk of thrombotic tendency, and based on that, you decide what kind of anticoagulation the person is going to require. Similarly, if he's got a high risk of bleeding in low disease, you definitely won't give it. But if you have a high risk of bleeding in moderate to severe disease, you'll again give some anticoagulation, may not be so aggressively. So these scores, if we have them in our ICU where these critical patients are admitted, and calculate them on a daily basis upfront, we know that what kind of anticoagulation we are going to give them. Next slide. This is the same thing which I said, 40, 60 and 60 twice daily, different kinds of this thing. Now coming to another question, that is, in hospital we've decided what we are going to give, and in hospital it would be better to give heparin rather than any oral anticoagulants. But once these patients are going to get discharged, we need to decide whether they require any anticoagulation post-discharge. Now, how to decide if a person is going to require anticoagulation post-discharge, and if he requires, what to give and how long to give. This is a very nice score, which is a modified IMPROVE VTE risk score. And then you give a previous thromboembolism a score of 3, a known thrombophilia score of 2, current lower limb paralysis or paralysis score of 2, a history of cancer score of 2, stay in ICU for 1, and complete immobilization for more than 1 day 1, and age more than 60 is equal to 1. Next slide. So once we decide whom we are going to actually give home anticoagulation, if the score by itself is more than 4, or score is equal to, is more than 2, but it is actually having a D-dimer more than 2, or elderly person more than 75 years, or age more than 60 with a D-dimer value more than 2, or age 40 to 60, a D-dimer value more than 2, and a history of VTE or with a diagnosed malignancy. And these are the 5 categories of patients who will require some sort of anticoagulation post-discharge. Now, what anticoagulation to give post-discharge is again a question. Warfarin and acetrom will be very tedious, not only because of the drug interactions which they have, but monitoring becomes extremely difficult, and then you don't want to have. So now for the ease, most people will go for novel anticoagulants, and then we have 3 choices broadly which we use. We have the direct thrombin inhibitors and the factor 10A inhibitors, and based on the characteristics we differently use. So all of them are recommended. They are predominantly studied with regards to atrial fibrillation, but with the patient characteristics you can use either apixaban, rivaroxaban, or a dabigatran.
And in your personal experience, where would these 3 stand, and how would you choose between them? Like, you know, many people are now kind of leaning towards using rivaroxaban because it has more flexibility in dosing and several of those factors. So do you think there are any features, because you have gone through it in so detail, that choosing one over the other has its advantages? Any thoughts on that?
Definitely, because you also need to take into account your personal experience with the molecule. Second would be what is the bleeding risk. Now, if somebody's got a high risk of bleeding, then you would avoid anticoagulants which have a higher risk of bleeding. Maybe rivaroxaban, in that case, you would probably avoid compared to apixaban. But if you want a good anticoagulation, then you probably would go for a rivaroxaban rather than an apixaban, where the anticoagulant is relatively mild compared to rivaroxaban. As I said, these are new molecules and we are not all aware of all the things of that molecule. And because these patients are on multiple drugs, it is always good to have known the drug interactions, because these COVID patients will be on multiple drugs. And inadvertently, if you give a molecule not knowing what interaction is happening, will actually cause more harm.
Got it. Thank you very much. I think you led us through in a very detailed manner through a very rational approach to anticoagulation when it comes to COVID and COVID complications. Dr. Sudhir, next question to you on the same topic, your experience with anticoagulant therapy when it comes to neurological system and either treatment or prevention, the kind of approach that you've been using and your choices and likes and dislikes and some of your insights for our audiences.
Yes, I think Dr. Abkari has very nicely summarized, the risk and benefit and also given various guidelines. So just I'll be specific about the strokes and in neurology. So if you look at ischemic strokes, earlier people used to, think that giving heparin will treat dissolve the thrombus and cure it. So that is not true. So heparin or any anticoagulation will not do that. And only method to dissolve the clot is by giving IV thrombolysis with alteplase, or now we have tenecteplase also, one of these two agents. And so the role of anticoagulation in a ischemic stroke patient is to prevent DVT. And we know that patients COVID-19, they have a higher risk of getting DVT and pulmonary embolism. And patients who have COVID-19 and stroke, they have a much more higher risk of getting DVT and pulmonary embolism. And based on the criteria proposed, those patients require, both heparin as well as non-drug methods that we have, pneumatic compressions, stockings also. And so that is what ischemic strokes. Hemorrhagic stroke, obviously we don't anticoagulate for the stroke, but again those patients also have a higher risk of getting DVT and pulmonary embolism. So after about 48 to 72 hours after the hemorrhagic stroke, also we can start low dose anticoagulation, because the risk of bleed worsening is not so high after that, and probably half the dose. And then by the end of a week we can go for full dose thromboprophylaxis, not the therapeutic anticoagulation. So the main role of anticoagulation comes in the venous sinus thrombosis, where the mainstay of treatment itself is anticoagulation, and we have been routinely using heparin in the initial stages, and then we switch over to usually warfarin. There have been studies on dabigatran, but it did not show enough power to show that it can be used as of today. But some patients where warfarin cannot be used due to some reason, on case-by-case basis or on compassionate grounds, dabigatran has been tried. There is no data on other NOACs like rivaroxaban or apixaban for CVST. And finally, I would discuss what is the role of anticoagulation in preventing strokes, because I have seen patients who have had high D-dimer levels, and they have been told by physicians that because your D-dimer is high, you have a high risk of getting strokes, and so you should be on anticoagulation. So again, and there have been few papers also where authors have recommended the same thing, that if the D-dimer levels are high, inflammatory markers are high, they should be put on anticoagulation to prevent strokes. Now, this is half the truth. As of now, the data is not enough to recommend this for all the patients. As I mentioned, that the risk of stroke is only about 1 to 1.5% of all COVID-19 patients, and maybe in severe COVID-19 it may go up to 5%. So, are we justified in treating 100 patients to prevent 5 strokes? Because the downside is risk of bleeding, because anticoagulation comes with the risk of bleeding also. So we have to carefully weigh the risk of bleeding versus the benefits expected, and case by case basis, definitely it can be given. And once we start anticoagulation, we should also tell the patients the risk of bleeding and various things that can happen, and and then we should have a timeline for how long we are going to use that, because the risk does not remain high for several weeks. Maybe the first few weeks are important, so that the timings duration also should be decided. So I think as of now, the role of anticoagulation is not very high, except in patients who have atrial fibrillation. They definitely need anticoagulation to prevent ischemic strokes. But barring that, just with severe COVID-19 high D-dimer, blanket anticoagulation should be avoided. But case by case, definitely there is a case to do that.
Okay, all right. Thank you very much. I think we have had a lot of questions come in from our audiences, so I'm going to start taking some of them. I shall direct it to one or all of you all. Anyone who wishes to answer can answer it. This is a very interesting question. In home quarantine patients with red flags, are there any indications to start either antifibrotics or anticoagulant therapies? Because we know that there have been phases where there were no hospital beds, there were, a lot of issues. So are there any situations in which someone is being treated? I think what they mean is home isolated patients. Quarantine is when you don't know whether there's an infection or not. Isolation is when you know they are infected. Any reason to start anticoagulants or antifibrotics? Dr. Kapil or Dr. Srirang? Dr. Kapil, if you want to take this.
Yeah, so the answer is very clear. There is no role of antifibrotics, especially in these cases, because starting you don't know what is the disease like or how sick it is. Probably if it is home isolation or quarantine, they are mild disease, so probably will not require anything except good nursing care and probably some symptomatic medicines. Now, coming back to your anti-thrombotic treatment or thromboprophylaxis, yes, in certain subset of patients who are home isolated, we might tend to give anticoagulants or thromboprophylaxis in this patient, especially those patients who are maybe an underlying maybe an ischemic heart patient or an obese patient or probably a known case of any other surgeries in the immediate past or something like that. So all these high risk patients with high comorbidity and red flags, we might tend to give antiprophylaxis or thromboprophylaxis. And to be honest, I have been giving this thromboprophylaxis to very small subset of patients who are home isolated, whom I feel they are at a high risk. Obviously, after calculating all the risk versus benefit ratios and everything, but we tend to give at least thromboprophylaxis in some patients, not all, but absolutely no antifibrotics.
Great. Dr. Srirang, your thoughts on this question, because I think this is a very practical and important question faced by a lot of physicians.
Giving anticoagulants to patients at home carries a huge risk. As Dr. Kapil rightly said, there will be a small subset of patients who are at high risk. Maybe they are otherwise all right, but the markers, inflammatory markers are high, D-dimer is high. Probably they are not requiring admission for other things, or they require admission, but they are not getting a bed. But remember that anytime you give somebody on anticoagulation at home, you need to be extremely careful, assess whether he's at a high risk of bleeding, and then following up him every day. Because if he bleeds, you will never know. He'll be all alone in an isolated room, and then you won't know what happened. So there would be a subset of patients of high risk category. So baseline would be continue your anti-platelet and statins if the person is already on for any other indication. And if over and above that you require anticoagulation, be extremely careful, explain them the risk, and then do that with daily monitoring. But it would be a very small subset of patients. Second way, we faced a larger number because there was no bed availability.
Got it. The next question is, how do we titrate the dose of rivaroxaban between 10, 15, 20? Again, we are talking about patients who are getting discharged from the hospitals, patients who might be at home and are at high risk. What is the a general approach that can be understood, like, given the higher dose versus the lower dose? Dr. Rathi, you would like to take that, or Dr.
Yeah.
Sharma after that? Yeah.
So I'll just answer it very briefly. The typical dose of rivaroxaban is 15 milligram BD that is for absolute proven AF, where you want to have a stroke prophylaxis or a proven DVT and pulmonary embolism. So their dose is 15 milligram BD for probably 3 weeks and then followed by 15 milligram OD for 3 to 6 months. So that is very standard. But as a thromboprophylaxis, generally we tend to give patient rivaroxaban in the dose of 10 to 15 milligram, on higher side 15, otherwise 10 milligram is good enough of rivaroxaban. And typically what we give is for maybe 45 days to 60 days. So that is what is our unit is following the trend. Otherwise, for therapeutic, it's a different dose. For prophylaxis, it is between 10 to 15. We generally tend to be on a safer side on a 10 milligram. That is what we do.
Good. Dr. Srirang, your thoughts on that? Anything you would like to add to that, or?
I would agree with that. Once you calculate what dose you want, is it a prophylactic dose or a therapeutic dose, and then based on that 20 or 10 milligram would probably be the one which you would give. But again, be very careful in monitoring, and then confirm, because these are new drugs, everybody is not aware of it. So, and what if you just give a molecule, sometimes patients don't look at the dosage, they just take the molecule what is available and take dose. But here you need to be extremely careful. So I agree with Dr. Kapil regarding the dosages.
Great, sounds good. And I think one point that was raised earlier, we all have to remember about drug interactions in general, because many of these patients are on polypharmacy and they may be taking multiple things together. So I think it becomes very important to keep that in mind of adding one more medicine to their list and regimen, and remembering to reassess it so that, as was said, 45 to 60 days, somewhere in that time frame, discontinuing it if you feel that they are outside the risk zone. One of our audiences asks, are a high IL-6 or a high D dimer indicators for fibrosis, for pulmonary fibrosis? Any thoughts on that from any of you all?
As Dr. Kapil has said in his talk, high inflammatory markers are actually going to predict a severe disease and a high risk of fibrosis. So they would form part one of the risk factors, and other risk factors as elucidated: elderly age, maybe the history of smoking, alcohol intake, maybe particular radiological patterns like air bronchogram, dense consolidation, diffuse reticular patterns, those parenchymal bands. Some people with effusion also, although it is rare, they have actually known to progress much more. So they would actually should be taken in whole as a whole, and then predict the risk of fibrosis.
Got it. When should antifibrotic drugs be started, and for how much duration should they be used for?
Okay, so again, that's a $1 million question. So you have to, this is very subject. This is very case to case basis, and you can't have a blanket therapy for all. So it all depends on, like I've told you, it all depends on case to case. So if I feel that patient has developed, say, early fibrosis, or there are subtle markers where you can see that fibrosis is setting up, I'll start right away on the time of discharge. So probably my discharge card will have, something like nintedanib or pirfenidone, depending on the availability. So I'll start that. So how long I'll start probably with 100 milligram twice a day. If I'm using nintedanib, I probably will use for at least 3 months basically, and then I'll reevaluate according to the the clinical scoring system, and as well as the radiologically. So this is how it should be. But that doesn't mean that every patient who's coming out of ICU or hospital will require antifibrotics. So that is very clear. It is very subjective, very case-to-case basis. It is your judgment. It is patient clinical profile. It has certain radiological findings, which will altogether will make a decision whether to start antifibrotic. But yes, minimum 3 months is something which we give, and we have given first phase. So first phase probably we have given as late as up to 1 year also. So it all depends on patient to patient, but this is how we approach for an antifibrotic.
Sounds good. The next question is, I kind of know we know the answer to this, but since it has come in, I think it's worth taking. Do we have to start antifibrotics for all potential COVID ILD so that they don't turn into fibrosis? This is a tricky one in some ways, but again, I think you've answered it. Dr. Srirang, if you want to take that.
Yeah, I think there was a very elegant review on this antifibrotic agent by Dr. Udvadia et al., who have really told how it is going to happen. Now, you have known the risk factors of fibrosis, you identified how the fibrosis looks in the initial stages. What are the subset of patients actually needed? The only ones who need it are who are likely to progress, and as Dr. Sitesh presented, you saw a patient who had a bad looking CT actually improved by recovery. It is very difficult to predict who is actually going to recover and who is going to require. But as Dr. Kapil said, at discharge, when you do a CT and then you still find a lot of ground glassing there, a lot of interstitial thickening, fibrotic band, those are the kind of patients they probably will benefit. And as he rightly said, a minimum duration of 3 months is what is required for them to have any effect, as seen in the IPF studies. So minimum duration, at least 3 months is required, extendable based on the clinical scenario. But we also need to remember that if at discharge there is some ground glassing which is still continuing, a low dose of steroid may be continued. Now, all of us are aware the steroid-related side effects, hyperglycemia, mucor, etc. But a very small dose, about 20 milligram of prednisolone per day, might help in actually improving that ground glassing early and preventing fibrosis from occurring. Good oxygen supplementation along with anticoagulation will help.
Great. The next question that we have is there any reason, if for some reason a patient has to be shifted from pirfenidone to nintedanib, does it really affect the patient's health? And is there any advantage to using nintedanib over pirfenidone in such cases? Like, is there some advantage why we would choose one molecule over the other? So I would like both of your thoughts on this, Dr. Srirang and Dr. Rathi.
So, the both molecules are, they are both antifibrotic, but with a different action. So probably we all know, nintedanib is, tyrosine kinase inhibitor and has got a very particular affinity or blocking, the platelet-derived growth factor and vascular endothelial growth factor receptor. So probably more specific, while on other hand, pirfenidone is more studied molecule, more used molecule in clinical practice, but has got the down regulation of fibroblast and collagen. So there are two different modalities which are operating. But if you ask me, if a patient is started on pirfenidone and then shifted to nintedanib, probably a shade better here and there, but not a very huge, vast difference. In fact, a lot of people have used combined this molecule both together also. But again, everything comes with certain, side effects. So we all know we have to monitor the liver functions, the bleeding tendencies, and everything. And we all know patient will be on trauma prophylaxis with either rivaroxaban or whatever. So you have to be very careful while monitoring this both molecule along with the trauma prophylaxis so that it doesn't bleed, because they actually potentiate the action of other. So you have to actually balance out it very well. But to answer your question specifically, there is no there is very subtle advantage of shifting from one molecule to another. So thought in your mind what you have to start, probably because now it is available off patent, cost effective, simple dosing twice a day, easy to take, no need to monitor it, that far, and probably not to titrate too far, which pirfenidone has to done, because we all know pirfenidone has to be titrated till 2400 milligrams. So that is where sometimes, the patient get lost to follow up sometimes, and that issue comes. So that's when nintedanib becomes an automatic choice, and it is more specific to that, the platelet and the other factor, so that, that the antifibrotic activities are shared better than pirfenidone.
Great. Your thoughts on that, Dr. Srirang? Anything you would like to add? Or
I would agree. In COVID-related disease, probably nintedanib has a better outcome, probably largely due to the mechanism of action and the mechanism of damage of the lung which is occurring in COVID-19. So monitoring wise, LFTs, dose titrations much simpler with nintedanib. So we've also used in a wide variety of patients, and then we found it easier to manage, well tolerated, and the basic side effects, but much better experience with nintedanib.
Great, thank you. There's a question about newer molecules in COVID-19 management like molnupiravir and baricitinib. Any thoughts on these? Anyone can take it.
Yeah, so molnupiravir is still yet to get an DCC approval. Probably within a month or so, we should be able to get that molecule in the market. For very last study of I've used in more than 150 plus patients. Obviously, along with remdesivir, that is what is the standard of care. And we found it very useful, to be very honest. And I think that combination works very well. Even in a sicker patient, if you start it at the right time, probably then the outcomes are very good. And after that, a lot of Indian company coming up with baricitinib and getting it cheaper. So probably we are more well versed with that. So I don't know, maybe my colleagues will have the same experience what we have in Mumbai. So baricitinib is doing well. So probably it is avoiding tocilizumab in a lot of our cases.
And also, I think the timing of using it at the right time and getting it into the system, and it's only a single dose. So all of those advantages are definitely there. Dr. Srirang, anything you would like to add to that?
Yeah, I agree. Baricitinib again is a very useful molecule. It aids in the anti-inflammatory properties without having so much of the side effects of tocilizumab or high-dose steroids. And then in our experience also, we found even one of our relatives who had that very bad lung at presentation. The problem with COVID is that one of the things to prevent severe disease is to suspect COVID. Because a lot of times what happens is I don't have a cough like COVID. So I've never gone home, so I've not got COVID. So that is the commonest presentation, and because of that, testing is delayed, diagnosis is delayed. And in such patients, when they present late, remdesivir steroids are given, and then when you rightly select baricitinib, it has a very good outcome. And then initially availability was a problem, but now it is very well available. High cost was quoted, but that will easily surpass the hospital stay and other complications which we find, and a very gratifying outcomes.
Dr. Sudhir, I'm not directing any questions to you. Looks like all of the questions are related to the pulmonary side. If you want to chime in on any of these newer molecules, if you also have experience using them in any of your patients, please do chime in. The next question is about cocktail antibodies. Okay, your thoughts on use of that. We have the product, and where do you see the role for that? And do you think that the combination of the cocktail antibodies will be of value during the third wave, because everyone is scared that if we get the Delta variant maybe evading these antibodies, and if a Delta plus comes out with multiple mutations, then will these still work? So your thoughts on that?
Yeah. So I think let me put my hand first, because I have used in almost 8 patients now. So this antibody cocktail, Reparenon or Cassi-IM antibody cocktail, what we use. So to be very honest, whatever patient I have used, the drug has done wonders. Obviously, we have to choose our patient rightly, and we have to time it very rightly. So that is very important. So it's not for any patient who's admitted with hypoxia or on a ventilator, or getting into day 9, day 10 of the disease and coming to you in a sick transfer from some other unit to your unit, and then you will start. So this is practically for mild to moderate case, one. Number two, it has to be given ideally within 3 days, maximum 5 days, and long 7 to 8 days. So this is a very important message. And 3, you have to find, because it's a costly affair, 60,000 for a single dose. So you have to, but luckily now insurance company is also covering cocktail, so that should be eased out. And regarding the use in third wave, I think we are going to use it a lot in third wave, because a lot of this patient, and we all know a Tossi can cost you 60,000, or any Tossi in black market was costing 2, 3, whatever. So for that matter, 60,000 is not much as compared to, and it's OPD procedure. You have to give injection over 30 to 45 minutes. You just monitor for 1 hour, and that's it. Your patient is at home. Probably this will help our patient from not going from mild to moderate to severe disease, and practically evading all the complications. So practically will not require thromboprophylaxis also, practically will not require antifibrotics also, if you use it in the right way initially. So that way it will help a lot of our patients. The only thing is that little costing, probably that will save. Now, it was working with Delta variant. Delta plus, there are some data that it evades, or it has got breakthrough in spite of having COVID antibody cocktail. So, but time will tell. But as of now, it is working. And practically all my patients are, they were absolutely by day 7, they were RT-PCR negative, and nobody has required any hospital admission.
Great, thank you.
The antibody cocktail again should be carefully chosen in patients who are at very high risk of having complications or worsening. So that is a primary thing we should keep into mind. Second, since it is to be used early, we need to diagnose the patient very early. Generally people wait, mild disease, let us do a testing later. But here, if you're thinking of it, test very fast and then take a plan. Recent study in June also has come where in seronegative patients with moderate to severe disease, not on ventilator requirement, but requiring maybe oxygenation, high flow oxygenation, it has been tried with improved outcomes compared to standard care. Rightly, it has been said that it should be used in mild to moderate without high oxygen requirement, but the recent study has come wherein that subset of patients who are not able to mount even an IgM response to the COVID, and they have moderate to severe disease, hospitalized, requiring oxygen, not to the extent of invasive ventilation, there again they can be used. Otherwise, in regular patients, if they are used in that subset, they actually have a poorer outcome. So we need to really select that. But this new window is there, especially in neutropenic patients, sepsis patients, where you don't want to use steroids. This in a seronegative patient probably would do some wonders.
Great.
I'll add just one point here, because
yes.
So this antibody cocktail, our hospital MD, Miss Sangeeta Reddy, she also used it. She has tweeted this. So I think it's in public domain. So maybe she doesn't want to hide it. So, and she was very thankful for this, that she got it at the right time, and she gave the credit to the antibody cocktail for her recovery. So she had tweeted about a 6 week back, and so she has benefited from in our hospital. That much I know. Other patients I'm not aware, because we have a separate team taking care of COVID-19.
True. They come to you. They need you much later.
Much later. I'm happy if they
And for
don't.
different reasons. I think Donald Trump made antibody cocktails as famous as it could ever get. So I think your MD CEO would certainly add to that and add people's confidence in using it. But as was said, with the right indications at the right time, I think that's the key message that people have to have. I've got this question multiple times. Can nintedanib and anticoagulants be given together? I'm assuming that people are concerned about the potential, as you said, for the bleeding. So if needed, can they be used together? And if someone is on such medications that increase the bleeding risk, then is pirfenidone really a better choice if you're doing that? Any thoughts on that from any of you all?
Yeah, they can be given together, because since nintedanib is it inhibits that platelet-derived growth factor, so it has got a tendency to get a higher bleeding. So that is theoretical. Practically also, we have not seen too much of bleeding. So with 10 milligram of rivaroxaban, if you give nintedanib, we have not seen almost 100+ patient what we have used. Practically, we have not seen anything. But yes, theoretically, you have to monitor them. So you have to do certain tests or certain markers what you have to do. And if you're given a choice, if there is a high chance of bleeding right away on the time of discharge or patient present with that, you have to change to pirfenidone, which has got a little lesser tendency as compared to nintedanib. So that is how we take it in a clinical practice.
The next question that we have is, what is advisable? Waiting for fibrosis to set in and then start treatment, or take an approach where you start it early so that you don't end up with fibrosis? I know this is a very tricky question and I wish there was an easy answer, but just your thoughts on that.
I think I'll ask Dr. Abkari to take that, because it's a tricky one.
I think our whole aim is to actually prevent a lot of fibrosis. And then when you're thinking of that, you need to really start upfront. Patient with severe disease, prolonged ICU stay, at discharge, the CT is still showing significant lung involvement, which is there. Stratify them according to the features, and then you start them upfront, and then you will follow them up definitely. Those are patients, like Dr. Kapil said, they're requiring home oxygen as well. So in those kind of patients, it is better to start upfront, and then about 8 to 12 weeks down the line, you will know the difference which is happening. There may be a subset of patients who would otherwise have recovered by themselves also, but that is a chance we'll have to take. But you are trying to prevent fibrosis, and even you can manage to do that in even 50% of patients whom you have treated. That would be a great achievement.
Great. Thank you. This will be one of our last questions. We're almost coming up on our time. What should be the minimum and maximum duration of use for nintedanib, and on what basis do you decide that?
So in fact, we have answered that question. The minimum will be at least 3 months. You can get result before that also. It is not like that the 3 months is an absolutely deadline where before that you can't see. Probably for some other reason, if you do scan before that, you might see certain improvement. But at least 3 months is something which I will give to my patient or to my drug to actually work on that patient. And probably on the higher end, how long it should be given, I think that still remain unquestionable. A lot of people don't know answer. We keep to go on. We all know we have to carry on, because once that dense fibrosis or honeycombing comes up, then it becomes very difficult for this patient. Their survival and everything becomes very challenging. So I have a lot of my patients who are from first wave are still on antifibrotic nintedanib or pirfenidone. They are still, and they are practically they are stabilized on that. So I don't dare to take out that antifibrotic, because the moment I take out, there will be some kind of worsening. So probably I'll wait for some more time, but at least 3 months to start, and the extension can be as long as probably 9 months, 12 months, or 15 months. So that is something which we have to wait and watch and do very individualized kind of a treatment.
Sounds good.
It is something akin to preserving whatever renal function you got in end-stage renal disease. So when you have a lung fibrosis, and if you can really halt it at that using these agents, you still have a lot of good outcomes clinically, and that would matter. So I totally agree with Dr. Kapoor.
Great, great. There is a question that is very interesting. When I first read it, I said, why is this person asking it? But I can think why. They say, will remdesivir still be useful in the third wave? I think they're going with all these new drugs that are coming. There's molnupiravir, there's antibody cocktails, there's baricitinib. With all of these things in place, will remdesivir still be useful in the third wave? I hope we don't have a third wave, but we all know that the risks are there if people are traveling as much as they are and not following the mask guidelines and everything that they are. Already what I'm seeing, people are feeling like it's over, and they are going by all the news channels which are saying that we now have 67% seropositivity in India, and I think people are into a false complacency. So in case we have a third wave, will remdesivir still be useful?
So to me, yes, but there is no other direct antiviral which is available, and whatever data is there or whatever is there, we all know practically. And in fact, our Mumbai data from KEM Hospital and other things, so both for TOSI as well as remdesivir, it turned out to be quite positive data. And we also know in practice, the remdesivir works. The only thing is that it has to be used rightly. So it has to be used at the right time. That is very important. So I think if we use, so there is no direct RDRP inhibitor which is available as good as remdesivir, which is an antiviral. So probably it is going to work even in the third wave. So no matter what kind of variant comes, remdesivir is still going to be useful as an antiviral. The only question is how long and when to use. So that should be something which you have to be predefined when to use and how aggressive you have to be. But to by best of my thought, I think remdesivir is here to stay for a longer period of time till the time the pandemic becomes an endemic.
I totally agree. It's a good drug, and whatever the trial says, our own data, our own experience with a lot of patients on remdesivir steroids really speaks volumes that, okay, this definitely works. The initial problem was waiting for hypoxia, where I personally felt it was too late to start that, and maybe a worsened patients. In non-hypoxic patients, persistent fever at the end of first week, persistent or increasing cough at the end of first week with high markers, probably that is the time where you don't have the set limits of hypoxia as well. You still start them on remdesivir early, prevent the viral related damage, and then still you can have a good outcome. So till we get a good specific antiviral drug, I think that is going to stay. We need to use it judiciously at the correct time and not hoard it or...
Great. I'll take one last question because it's very relevant to our discussion. What is the dosage for pirfenidone and nintedanib for ICU patients, IPD patients, and discharged patients? Anything to suggest or say? A brief answer, just some ranges for our audiences.
So I don't see any reason for my patient for COVID-19 in ICU to be started on any kind of antifibrotics. They will be absolutely on discharge. But during ICU stay or during the COVID stay, probably they will be on steroid and other stuff rather than on a
antifibrotic.
But on discharge, yes, to start with, generally we start with pirfenidone with some people start with 200 milligram TDS. I generally start with 400 milligram TDS, or then we have got 801 milligram tablet also. So practically we can start with that. But typical dose is 200 TDS to 400 TDS to start, and then gradually build up in 2 to 3 weeks to a therapeutic of probably 2400 milligram per day. And for nintedanib, we generally start with 100 milligram BD for at least first 7 to 10 days, and then once one patient tolerate and there are no side effects, the liver profile and everything is normal after a week, then we tend to go to 150 milligram, and that we continue till the time there is any adverse event.
Sounds good. I would like to really thank all our panelists for a fabulous discussion this evening. I think we've gone through a gamut of very wide, varying topics related to COVID complications and post-COVID complications and their latest line of management. A very special thanks to Hetero Healthcare, to Pallavi, to Mr. Shastri and the entire team there for all of your support in making these possible for our audiences. Our audiences have been immensely interactive. There's a long list of questions. I tried my best to get through all of them. And thank you so much for being there. And again, Dr. Kapil, Dr. Sudhir, Dr. Srirang, fabulous job. Thank you. And to all the audiences there, take good care of yourself first, as I rightly said, and then everything else comes in place. So look after yourself, your families, and then all your patients with all the guidance that we are trying to provide to you all. And thank you very much. Over to you, Pallavi.
Thank you. Thank you so much, sir. Thank you for such an insightful discussion and sharing your experience with us tonight and with our audience. Thank you so much.
Thank you.
And I'd like to thank Dr. Sitesh for wonderfully moderating the session. As usual, he has done a wonderful job. Thank you, Sitesh, for asking all those tough questions. And probably we try our best to give answer. And I thank you, my co-panelists also, who are from Hyderabad. So thank you, sir, both of you for coming and joining us. Thank you so much.
Thank you, Dr. Sitesh. Wonderfully coordinate among all of them. It looked like we are actually working on this since many programs, and this is our first program together. Wonderfully coordinated. Thank you. And thank Dr. Kapil and Dr. Sudhir for a wonderful program we've had. Thank Dr. Hetero for having us all here and then sharing your experiences. Thank you.
Thank you, everyone. I think it was a wonderful session.
Thank you. Thank you, Dr. Sudhir. Good night to everyone. Take care. Stay safe.